Now, another important topic in pediatrics is care of the newborn. Now, this is a very basic topic for the students because this life starts from the newborn period, isn't it? And this newborn period, a neonatal period, is one of the very important stage of our life. In pediatrics also, uh, the according to the duration of a pediatric age group, it starts from the birth till 16 years of age, and from the birth till 28 days is called neonatal period or newborn period. And again, that is divided into early newborn or a little bit late period. So a lot of different classifications are there, but this care of the newborn topic is very important one. So in this topic, we talked about what are the usual principles of caring for the newborn baby, then what we do inside the delivery room or in the labor room after the baby is delivered, what is Apgar score, okay, how we give Apgar score at 1 minute and 5 minutes and how we interpret it, what are the normal vital signs in the newborn baby, how we routinely examine the baby to detect the congenital anomaly and some other abnormality, how we take care of the baby in the nursery, and what are the danger sign of the newborn. Okay, so all these things we're going to talk. Okay, what are the basic principles of essential newborn care? What are those principles? Okay, what should we do in this essential newborn care in the hospital or even at home? But mainly we talk about this in hospital. Number one, to ensure the adequate oxygenation through clear airway and proper breathing is one of the important principles of newborn care. We should make sure the baby is breathing normally and the baby is having clear airway. To prevent hypothermia in the neonate. Now, what is hypothermia? Yes?
When the body temperature is less
Body temperature decrease.
Exactly. Very easy question. When the core temperature or the body temperature is lower than the normal, it is called hypothermia. It has got different reading, okay? The normal body temperature, you all know, it's between 36.5 to 37.5, like that. If it is lower than this, then we call it hypothermia. Lesser than 35 degrees centigrade is a very definite evidence of hypothermia. So to prevent hypothermia, the environment should be kept warm all the time, both in the hospital or at home. To encourage early and exclusive breastfeeding for healthy neonate, a suitable method of providing nutrition to weak and sick baby who cannot feed on breast and get adequate nutrition. So let me explain a bit about this. Healthy newborn, no problem at all, full-term baby or even preterm who can breastfeed, we have to give exclusive breastfeeding and early breastfeeding. Early, within half an hour of delivery, the baby must be breastfed for the first time within half an hour. Okay. Now, what is exclusive breastfeeding? What do you mean by that? Exclusive.
It means feeding around about 6 months.
Okay, good. Good answer. Only breastfeeding, nothing else. That is called exclusive. Only breastfeeding till 6 months of age. Okay, even no water. There's no other food at all. Exclusive, only breastfeeding. But many of the family, they cannot strictly stick to this. So we can modify this up to 4 months also. But according to the World Health Organization, it has to be up to 6 months. But if some baby cannot breastfeed, they cannot suck on the nipple, they are weak and sick. So how to feed them now? There are two important ways. One with the help of a spoon, another with help of NG tube called nasogastric tube. Spoon feeding and NG tube feeding. These are the two best way to feed weak and sick baby. And sometimes even the baby cannot tolerate that type of feeding, then IV nutrition is one of the alternative. IV, intravenous nutrition, is also there, but that is only done in very, very selective babies. Now, another basic principle would be there are suitable measures to prevent neonatal infection. Now, how to prevent neonatal infection, especially in the hospital? As a medical student and as a developing doctor, you must know this. Whenever you examine a baby, especially the neonate, you must wash your hand and then only touch that baby. After you finish examining that baby, before you examine another baby, wash your hand again and then only touch that baby. If you do not do that, the infection from one baby can be easily transmitted to the other. Every nurse who take care of the baby should do the same thing. All the doctors must do the same thing. And when I enter into the nursery or neonatal unit, preferably I should wear a cap. Okay, I should wear the mask. I should wear the gloves and the gown, preferably. It is not applicable everywhere, but preferably we should do this. Another point, there is early identification of at-risk newborn. Early identification of at-risk newborn has to be done, and that is done by good history taking and physical examination. After we identify them, we should manage and stabilize them if we can. If we cannot do this in our center, then we should arrange for a safe transfer to a suitable advanced neonatal care center. Now, this is a very, very important point from our perspective, because many of us are from the developing world and there is not much facility in our countries, especially if we are on the remote area. There may be one hospital which is managing all type of patient. Now, what we do there? If we can, okay, we treat the baby there. If we cannot, we refer this baby, okay, to the better center. How far is that center? I should make sure about this. Who will go with this baby when I'm transferring? I should make sure about it. Do not only send parents and that sick baby to the hospital. Okay, probably the baby may die on the way. So if we have manpower, one nurse or one doctor, some junior sort of doctor, should accompany those parents till the hospital. They should hand over the baby to that hospital and then only return. So these are very, very important steps. Otherwise, it's just like dumping the baby, Oh, I cannot treat your baby here. I don't have any facility. Okay, you can go anywhere, wherever you like. That is not the way. We should help them to go to the another center. Now, after going through this important principle, let's collect some of the data, okay, before we take care of this baby. Now, see this information, so many times we have revised this till now. Collect some important information regarding the delivery, whether it is spontaneous delivery or induced delivery. Now, spontaneous, it's on its own. The labor pain has started on its own. No use of any drugs there. And induced means either the use of drug, okay, or because of the artificial rupture of membrane. These are two important ways for the induction of labor. We'll talk about this, or you will know this in obstetrics later on. Are there any complication of labor or not? Ask this question. Is there fetal distress present or not? Now, what do you mean by fetal distress? Yes, what do you mean by that?
Heart problem.
The baby experienced some oxygen deprivation, sir.
Good. I completely agree with your description here. Okay, always try to answer on your own way. He's right, actually. Fetal distress means fetal hypoxia. There is oxygen deprivation in the baby, and that can be manifested by two ways. One, fetal tachycardia, another is fetal bradycardia. And there are different ways by which we can detect it. Okay, If during the checking or examination, it is clearly mentioned there what is the fetal heart rate, you just follow that, and if there is something wrong, they will quickly deliver the baby either by cesarean section or by instrumental delivery. ROM is a rupture of membrane. Okay, so how many hours before the membrane have ruptured? What is the color of the amniotic fluid, and is it spontaneous or artificial? So these are the important questions. So let me highlight a little bit about it. Now, regarding the rupture of membrane, if a lady has come to the hospital after 18 hours, okay, rupture of membrane means there is a gap of 18 hours after the rupture of membrane and coming to the hospital, there is already a risk of infection to the baby. So what I mean here, the gap should not be more than 18 hours. Number 1 point. Number 2, color. The normal color of the amniotic fluid is watery, okay, watery color. If it is a different color than that, it is abnormal. If there is presence of meconium in the amniotic fluid, and if the baby has passed that meconium inside the uterus, probably it may look green in color, it may look golden yellow in color, something like that. So important question. And is it spontaneously ruptured, or the nurse or the midwife or the doctor has done it in the hospital? These are the important questions or important information for we pediatrician. Now we are talking from the pediatrics point of view here, okay? So these are the important points. What are the medication used in mother? We should take that history all the time. Who knows, some of the medicines may be harming the baby. What is the duration of labor? Always ask this question. Prolonged labor is not good for the baby. Is it vaginal delivery or cesarean section? Ask that question all the time. And what is the fetal presentation? Now, fetal presentation in majority of the cases, it is cephalic presentation or head presentation first. In some other cases, okay, buttock presentation or lower leg presentation, which is called breech presentation, and very, very rarely even shoulder presentation can be there. So these are some of the important information I want to know, okay, if I am pediatrician. Now, what are the requirements in delivery room? So what we need in the delivery room so that we can take care of that newborn baby? See here, the delivery room should be warm, okay, the temperature must be maintained. It should be slightly on the upper side actually, probably 28° or even more than that. The resuscitation equipments are there or should be there, like radiation warmer and resuscitation box. This radiation warmer is a setting, okay, it's a table like setting which is there in the every delivery room. It has a light source, it has a heat source, and it has got a certain height, so that even if resuscitation is required or necessary, we can conduct it very easily there. There is a heat source, there is a light source, okay, and there is a good height, so we can resuscitate the baby there. We can examine the baby there. We can change the dress of the baby there. We can give oxygen to the baby there. So everything can be done in radiation warmer. Resuscitation box, there's no need of any discussion. It has to be there. Who knows which baby needs resuscitation, isn't it? So it has to be there. If it is not there, and if the baby needs it, then there is no time to go and find it. Every minute, every second is important there. Okay, so it should be ready in the delivery room. Now, what are the things that should be present inside that resuscitation box? Yes, anyone? Now listen carefully.
Ambu bag.
Okay. Yes. Continue, please.
Ambubag,
Good. Anything else?
vitamin K.
Okay, so this may be a little bit difficult questions for you. So let me answer this. You just listen. Okay. This resuscitation box has a lot of the necessary instrument or necessary medicine which we need during resuscitation. One of them is ambu bag, is absolutely correct. Another may be laryngoscope. Okay. Another may be endotracheal tube. It should be there of different sizes. The ambu bag should be connected with the mask. Okay, the facial mask should be there. Then some of the drugs should be there, like adrenaline, atropine, okay, 5% and 10% dextrose, sodium bicarbonate, probably naloxone. Okay, all of these drugs should be there. So these are called important things in the resuscitation box. Expert person should be there. Now let me highlight on this. You may be wondering, now the baby is delivered in the hospital, so there may be expert person all the time. No, there may not be. Many of the time there is only one doctor who is running the hospital, and by that time the baby is delivered, the doctor may be somewhere else. Okay, maybe resuscitating another person or another patient. So the point here, according to WHO, expert personnel or health personnel should be present all the time when the baby is delivered. Now there is one important rule here. If one baby is delivered or a single baby is delivered, okay, we need 2 persons. If 2 babies are delivered, we need 3 persons, and if 3 babies are delivered, we need 4 persons. That means we need 1 person more than the number of babies delivered. Now, why is that? Because if resuscitation is necessary, I need the help. Okay, I cannot alone do all the things. If nothing is necessary, all is well, isn't it? You don't need to do anything. But if something is need to be done, I need help. So during that time, we need extra person. Referral system, if required, that means if I cannot take care of the baby in my hospital or under my supervision, I must refer this baby to somewhere else. Let's give one example here. Spina bifida, gastroschisis, omphalocele, these type of babies are delivered. What I do there, isn't it? I don't have any facility. So I must refer this baby to the surgeon, pediatric surgeon, okay, who can take care of this baby. So referral system also should be there if required. So these are some of the requirements in delivery room. Now, what type of examination I will do in the delivery room? Now, I'm going to talk about Apgar score, one of the very important concept in neonatology and pediatrics. Okay, so I want you to pay attention more here. In the delivery room, a minimal examination is needed, and the first sort of examination is known as Apgar score. Now see there, this Apgar score is done at 1 minute and 5 minutes of age or birth. At 1 minute and 5 minutes. So soon after the birth, we will evaluate this Apgar score. Now, how to evaluate this Apgar score? Let me talk about this, and I want to come back here again. See here. So all of you, please focus on your screen. See there for a few seconds. Okay, so now follow this. So let me use the highlighter. This is Apgar score. Now this Apgar score, okay, is named after a pediatrician known as Virginia Apgar, and this APGAR. Okay, so these letters are after these different types of criteria. So A is from appearance, P is pulse. Okay, in neonate or in the newborn baby we call it heart rate actually, but pulse and heart rate are the same thing here. G is for grimace. Grimace, we'll explain this. A is for activity and R is for respiration. See here, APGAR, Apgar. Okay, this is Apgar score. Now there are three score: score 0, score 1, and score 2. So how we give 0, 1, and 2? Let's talk about it. Regarding the appearance, if the baby is blue all over, means the baby is cyanosed everywhere, central cyanosis as well as peripheral cyanosis both, this is score 0. If the baby is blue only at extremities or periphery, but the central part of the body is pink, this is score 1. Score 2 means the baby is pink everywhere. There is no blue discoloration at all. So pink baby, score 2. Extremity is blue, score 1. Score 0, blue all over, or in some of the textbook it is also mentioned pale all over. Even the pale baby all over has a score of 0. Not only blue, pale. Okay. Let's go to the pulse or heart rate. No pulse or no heart rate. Heart rate is 0. It is a score of 0. Score 1 means heart rate less than 100 beats per minute. And score 2, it is more than 100 beats per minute. This is regarding the pulse or heart rate. Third is grimace. Now look at here. No response to stimulation. Now how I give stimulation to the baby? It is done by the suction tube, a very small tube which is attached to the suction machine will be inserted or will be put inside the nose of the baby, and we see the facial response of that baby. If there is no response to stimulation like that, 0 score in grimace. Score 1, okay, there is a slight type of grimace or feeble cry, and score 2, the baby sneeze, okay, sneeze, or the baby pull away when stimulated. This is score 2. Sneezing is considered a very strong type of grimace. Now, what is activity? No movement of the limbs, no movement of upper limb and lower limb. Score 0. Score 1, some movement, and score 2, very active movement. The baby is moving all the limbs, okay, constantly. This is score 2. And regarding the respiration, no breathing, okay, no breathing at all. When I constantly observing the baby, no breathing, 0. Score 1, weak or irregular breathing, like a gasping, even 1 or 2 breath, okay, can be considered as a score 1. And score 2 is a cry. You must have heard this. If a baby cries after birth, everything is all right. And that is a very true statement, because after cry, the respiration, the baby is breathing fine. And if the baby breathes fine, there is no problem of hypoxia. Everything else will become better. So crying at the time of birth is very, very important one. But some of the baby, they don't cry, but still they are normal. Okay? They are breathing fine. So you don't need to cry all the time. So these are the important point. Now, after going through this, okay, if the baby is having 0 score, what is the interpretation now?
Sir, he's dead, sir.
Cyanosis.
It's dead.
He's dead,
Okay.
sir. Confirmed dead.
Okay. So now see there. So my question is, if the total Apgar score for you is 0, means from appearance 0, pulse also 0, everything else is 0, the baby is born dead. This is a dead baby. Okay. So this is a dead baby. Now, what is the highest score in Apgar? Tell me, what is the highest score now? What is the
Score 2.
score 2? But if you add all the 5 together, what will be the highest score?
10.
Exactly. It is 10.
10.
Okay, it is 10 because there is a score of 2 from every parameter. So the highest score would be 10 and the lowest score would be 0. So never forget this. It is 0 to 10. Let's talk practically now. The score of 10 is never possible in a normal baby after the birth because there is one important condition known as acrocyanosis, which occurs at the time of birth and it will continue for a few hours. So let me write that term for you, acrocyanosis. Now, the meaning of acrocyanosis is, acro means periphery, acral part, okay, peripheral part. That means the foot and the hand may be blue, but the central part of the body is pink. And we give this a score of 1. So it is not 2 from the appearance side. So the maximum Apgar score which we can get practically is 9 only. Though theoretically the maximum score is up to 10. But practically we may not get 10, usually. Remember this. And if they ask you why, what's the reason for this? You simply answer, this is because of acrocyanosis, which is very common after birth. And acrocyanosis gets 1 score from the appearance side. And if everything else is also 2, then we only get 9 score. That's the important point. Now let's interpret it. Okay. Now see here. It is written here, a score of 7 or less indicates that an infant is at risk. Now, what is the risk? There is a risk of hypoxia. Okay? This is about the risk of hypoxic damage of the brain. Now, why the score of less than 7 is at risk? That means if we calculate all the score, if we add all the points, and if it is, for example, 5, okay, this baby is not up to the mark. So we recalculate the Apgar score again at 5 minutes. Again. And at 5 minutes, if the baby who is having Apgar score of 5 at 1 minute became 8 at 5 minutes or even 7 at 5 minutes, now I'll be quite satisfied. Yes, in the beginning, probably the baby was taking time to adapt to the new situation or new circumstance, or the new environment. But after 5 minutes, the baby has done it. So I am satisfied. But if it is still remain 5 at 5 minutes also, something is wrong there. Okay? Something is wrong. Then I have to find why the baby is not able to adapt. So these are a very, very important point. One more thing, if the score is less than 3 at 5 minutes, score at 1 minute is not that important, because I already told you the baby is adapting to the situation. But score at 5 minutes is very, very important because there is already enough time for the baby to adapt. If at 5 minutes also the score is less than 3, that is severely depressed baby or severely hypoxic baby. Probably the brain has already suffered from hypoxia. The same thing is written here, and in the exam, okay, probably in your homework also, I'll give some of the clinical scenario to you and ask to calculate the Apgar score. So please take the help of this table, okay, when you solve what is the total Apgar score in the baby. Now, how the question is asked, for example, a newborn we just delivered in the room, when we evaluating the Apgar score at 5 minutes, the appearance is totally blue everywhere, the pulse is only 50 per minute, there is very weak grimace, the activity is limp, there is no tone, and respiration is only gasping, something like that. One scenario would be given to you. Then according to this rating, You have to calculate the total score and answer the question. I'm sure you can do that. Okay, so let's move on. Now, after we do Apgar score, let's talk about the vital signs in the newborn. What are the important vital signs and what are the normal range? The vital signs include temperature, heart rate, respiratory rate, blood pressure. We should use an appropriate apparatus for the newborn, means appropriate cuff. Newborn, okay, they're the smallest creature, isn't it? So very uh, large size sphygmomanometer cannot be used to record the blood pressure in them. So appropriate sphygmomanometer should be there, and the blood pressure is usually measured in upper and a lower extremity. If you suspect congenital cardiac lesion like coarctation of the aorta, this is the must. Otherwise, simply measuring in the upper limb may be enough. Now, these days, okay, there is a monitor which has all these settings already. For example, if I apply the sphygmomanometer on the arm of the baby, then that monitor will show the blood pressure on its own. The heart rate is also shown there, temperature is also shown there, and respiratory rate is also shown, or even if it is not shown, you can quickly count it. So not that difficult at all. Now, please focus here. What are the value of these vital signs, the normal range of the vital sign in a full-term baby, I mean the baby who is born at 40 weeks gestation? The heart rate is 120 to 160 beats per minute. It's the same as fetal heart rate. It's the same like fetal heart rate. It may slightly decrease during sleep, because during sleep, the metabolic state is inactive, it is less, so heart rate would be low. In adult also, it is the same thing. Respiratory rate 40 to 60 breaths per minute. Try to remember this, 40 to 60 breaths per minute. Now, I like to highlight some important points quickly here. Now, see here, from birth, okay, from birth till 2 months, okay, from birth till 2 months of age, the upper limit of respiratory rate is 60 per minute. It is the upper range or upper limit. That means more than 60 per minute till 2 months of age is abnormal. Now, from 2 month, okay, from 2 month till 12 month, that is till 1 year of age, the upper limit is 50 per minute. More than 50 is abnormal, okay, and then from 1 to 5 years of age, from 1 to 5 years of age, the upper limit is 40 per minute. It is 40 per minute. So more than 40 is abnormal. So please remember this. This is a very, very important point. And if you remember, you can quickly diagnose pneumonia in this age group. And after that, it almost become like an older child. Regarding the systolic blood pressure, it ranges from 60 to 90 millimeter of mercury. Okay, 60 to 90. We'll talk about that systolic blood pressure in some other classes. See here, what about the temperature? See there, the temperature is 36.5 degrees centigrade to 37.5 degrees centigrade. So this is the normal range of the temperature. Lower than 36.5 is hypothermia, and more than the upper limit is fever or hyperthermia. Weight. Now, every student know what is the average weight in the newborn period. It is about 3 kg. Remember like that, 3 kg. There's so many things written there. You don't need to go after that because The weight varies according to the geographical location where the baby is delivered. So average is 3 kg. Length, shear. Though it is written 51 centimeter, we remember it like a 50 centimeter, 50, 50, easy to remember. Okay, and this is a good range, 48 to 53 centimeter. Regarding the head circumference, 35 centimeter is the average one, and this is the range, 33 to 37. So practice this, okay, till you are quite confident here. Now let's move on. Now, what are the other examination we do in the delivery room after taking these vital signs and after calculating the Apgar score? The infant is placed under a radiant warmer. We have already kept actually or placed. Okay, then only we calculated the Apgar score. Screen for evidences of life-threatening congenital anomaly and birth injury. Now, can you tell me some of the example of life-threatening congenital anomaly? Okay. What are those life-threatening congenital anomaly? Yes, guys? Anyone?
Bicuspid valve, bicuspid valve,
Polycystic kidney disease.
The polycystic kidney disease, PST, the coordination aorta.
Okay. Now I already got some of the answers from you. Okay. Now see there. These congenital anomalies can be major, can be minor, or can be life-threatening. So if we do not, identify or correct them in time, then the baby may die. These are life-threatening congenital anomaly. You can also call them major congenital anomaly. One of them, okay, anencephaly, isn't it? Anencephaly is a very lethal type of congenital anomaly. The life of that baby is few hours only, usually. It may survive for few days, but few hours is the lifespan. Another is spina bifida. Spina bifida, a very severe type. There are different types of spina bifida again, but the severe type I'm talking about, like meningomyelocele and myelocele. These are the very severe one. Another is gastroschisis. Gastroschisis. The whole intra-abdominal organs are visible from outside, okay, and they are not even covered by peritoneum. This is gastroschisis. And another is omphalocele. Again, the anterior abdominal wall is absent, but the intra-abdominal organs are covered by peritoneum. These are life-threatening type of congenital anomaly. Now, some minor ones are also there, like cleft palate, cleft lip. Okay, these are the example of a minor one. And internal type of congenital anomaly. Sometimes they may be difficult to diagnose at birth, like congenital heart disease. Somebody was saying congenital heart disease, like cyanotic type of congenital heart disease, or even acyanotic type. So this is a very important question for you in the exam. Okay, so please be prepared. Let's move on. The infant may urinate or defecate, indicating patency of these orifices. Right after the birth, the baby may urinate or even defecate. This is a good thing. This tells us the opening of the urethra and opening of the anus is patent. Okay, they are normal. After that, the gestational age is assessed based on neurodevelopmental sign, especially if you believe, okay, especially if you believe the lady is not giving proper history, or she is not sure about the LMP, or last menstrual age. In obstetrics, we have already studied how to calculate the gestational age according to the last menstrual period. So if we are not sure about that, then we need to examine the baby. How mature is the baby? According to the physical sign and neurodevelopmental sign, then we give certain gestational age. That is the meaning. After that, newborn care is given in nursery. Okay, nursery is the place where a lot of newborn babies will be kept, okay, for a short duration, and then they will be given appropriate care. Now, what are those things, okay, we do regarding the care of the newborn? Let's revise a little bit again what we do in the labor room or delivery room. Have a look here. Provide warmth, very, very important one. Now, immediately after I get the baby, okay, for example, what I'm saying here is when you as a pediatrician or as a doctor is called in the delivery room, okay, there are two important ways of delivery. One is normal delivery or vaginal delivery, we say, another is cesarean section. Now, after they get the baby out, they will hand over the baby to you. So it is your responsibility now after you get the baby. Now, what is the first thing you like to do? Probably the baby is wet everywhere because of the amniotic fluid. I will, okay, uh, nicely, okay, dry the baby, and the baby should be make warm now. Otherwise, hypothermia is very quick to happen. So provide warmth to the baby after making the baby dry. This process would continue, continuously drying the baby and providing warmth. Clear the airway. If you believe the airway is obstructed, if there is a lot of mucus coming out, give a gentle suction. Stimulate the baby. If the baby is not crying, we stimulate the baby, okay, and reposition the baby. Reposition means sometimes the head and the neck is twisted. Sometimes the neck is excessively flexed. This is not a good position. Okay, neck should be a bit of extended. So to maintain that position, I need to put a small, fold of towel, okay, on the shoulder of the baby so that neck would be hyperextended a little bit. Now, why to stimulate the baby and how to stimulate the baby? This is a very important practical information. Sometimes the baby doesn't cry. So simply stimulating the baby would make that baby cry. And cry is the excellent thing, okay, because when the baby cry, the oxygenation would be enough or adequate. Remember, cry has got two value or two score in Apgar score evaluation as well. But how to stimulate them? Some of the pediatrician or the doctor, they simply rub the back. They simply rub the back. Sometimes they rub the sole, and sometimes they flick the sole. These are the enough, okay, stimulation for the baby. And give oxygen as necessary. Not all babies need oxygen. If you think the baby is breathing a little bit faster, then only give oxygen. Now, how to take care of the eyes? Now, buy normal saline. So put some normal saline in the eyes, okay, it will be all right. And if you suspect gonococcal infection in the mother, to prevent that baby from the gonococcal infection of the eye, we can give 1% silver nitrate drops or 1% tetracycline or 0.5% erythromycin ophthalmic ointment in the eye of the baby. So all of these are preventive aspect, okay, from gonococcal ophthalmia. Another important term is ophthalmia neonatorum. So let me write that term for you. Ophthalmia neonatorum. Ophthalmia neonatorum is the infection of the eye at the time of birth. Ophthalmia neonatorum. Now, this ophthalmia neonatorum is a very broad term. Not only gonococcal infection is responsible for this, even chlamydia and other infections are responsible. But this gonococca is one of the common infection which cause a problem here. This is a conjunctivitis, severe type of conjunctivitis in the newborn baby. It will develop within few days, and there is a lot of pus discharge from the eye. Let's move on. Now, how to care the umbilical cord? Now, what we do to the umbilical cord? At the time of birth, when the baby is delivered, okay, so what the nurse or the doctor who is delivering the baby do? They will clamp that umbilical cord and cut it, then hand over the baby to you. Now it's your job. So you have to again secure the umbilical cord. So securely clamp the cord and take cord blood for investigation, especially in RH incompatibility. Group O mother, mother with maternal diabetes, and small for dates baby. So this baby needs some of the investigation. So why to prick the baby right after the time of birth? So rather than that, it would be nice if I take cord blood for the investigation. So see this, RH incompatibility, you already know the meaning. Mother is RH negative, baby is RH positive. This is called RH incompatibility. The baby may be having a lot of problem, so we need certain blood tests to confirm it. Group O mother and group A or B baby, this is called ABO incompatibility. Again, cord blood is investigated. Maternal diabetes mellitus, the baby, okay, after birth would become hypoglycemic, and small for dead baby, even this baby may get hypoglycemic and they may be polycythemic also. So cord blood examination should be done. Another important point, when the base of the umbilical cord is bulbous, when it is bulbous, bulbous means a little bit swollen and suspected to contain minor exomphalus, ligature should be applied distally. So what I'm saying here, do not tie the umbilical cord right next to the skin. You always leave a bit of a gap between the skin and umbilical cord. A length is left there, then only we tie the umbilical cord. Otherwise, if a small piece of intestine or intestine is coming out, okay, which is called exomphalus, and we accidentally tie that intestine and cut it, we are in big trouble right at the time of birth. So don't do that. Leave a small length of umbilical cord right there and tie a little bit above than that. After that, weight is taken and identity procedure is done. Now weight has to be taken at the time of birth. Now this is called birth weight, okay? And we want to know what is the birth weight of our baby. Everyone wants to know that. So this is a very standard procedure and you have to note it immediately. Another one is identity procedure should be done. Now, identity procedure means whose baby is this? Okay, whose baby? Now, whose name we write there? Because baby doesn't have its own name at the time of birth, isn't it? So whose name we write there? Yes?
The mother name or the father name?
It's always mother. It's always mother. There is no name of father at that time. It's always mother. Baby of, okay, mother's name. And we write that, okay, and we keep that in some part of the body, usually on the wrist. Usually on the wrist. So that is the baby's identification. If we forget to do that, and later on, if there is exchange of the baby, we'll be in big trouble. And many of the time this can happen if this is a very busy birth center. A lot of deliveries are happening at the same time, and if we forget to do that, big problem can happen. Now, a little bit interesting thing, sometimes what happens, so there are so many people inside the delivery room, isn't it? They are very excited to give the good news to the family. The families are eagerly waiting outside, and somebody went there and, oh, congratulations, you guys have got a male baby there. And everybody went, oh, male baby, wow. And after some time, you have not even examined the baby properly, and it turns out to be the female baby. Now, how can you show your face later on? So identity procedure has to be done very properly. You have to write baby of mother's name, what is the sex, and everything has to be done there. After that, vitamin K is given. Now this vitamin K is given at 0.5 to 1 milligram IM. This is intramuscular, okay, to all baby who weigh less than 2000 gram, means less than 2 kg. If the babies are born after traumatic delivery, and if mother had taken salicylate an anticonvulsant drug during the pregnancy, then vitamin K is the must. This is one of the indication, but many of the hospitals these days they give vitamin K routinely to all the babies. So you can remember like that. Vitamin K is necessary at the time of birth. Now, before we give first feed to the baby, now when the first feed is given, within half an hour, okay, we don't keep the baby hungry for a long time. But before that first feed, sometimes stomach wash is needed with normal saline. Otherwise, the baby may vomit the milk. So what are those situations where stomach wash is routinely done? Now have a look here. Meconium stained liquor or meconium stained amniotic fluid. At the time of birth, the baby may have swallowed that amniotic fluid which is already stained with meconium, and this meconium is an irritating substance, so definitely the baby will vomit until and unless we completely wash it out with normal saline. And how to do that? Insert a small NG tube till the stomach and wash it with normal saline. Very easy to do. Severely asphyxiated baby. Asphyxia means hypoxia. If those babies who are severely hypoxic, like Apgar score is less than 3 at the time of birth, we do not give feed immediately. You wash the stomach. Small for date baby, also they have very high chance of meconium stained liquor because these babies are usually hypoxic inside the uterus. And infants of diabetic mother, again, intrauterine hypoxia is very common. Whenever there is intrauterine hypoxia, there is chance of meconium aspiration. Now, following babies are taken to the nursery for care. We don't give these babies directly to the family because this baby may develop some problem. So we don't hand over quickly to the family. We observe this baby inside the nursery. So what are those baby and who are those baby? Now see here, birth weight less than 2 kg. These are very small babies, isn't it? Because the normal birth weight at the time of birth is 3 kg. So less than 2.5 kg is called low birth weight already. But they are even lesser than that. They are less than 2 kg. So they can have some complication. And if we do not monitor or observe, later on the baby will be in trouble. Less than 36 week gestational age. This is preterm baby. A lot of problem can happen. So let's observe the baby. Severe birth asphyxia. 5-minute Apgar score is less than 3. This is a big problem. The baby may develop seizure anytime. Seizure is very common in severe birth asphyxia. The baby may develop hypoglycemia. Rhesus isoimmunization or RH incompatibility. Now, what is the problem? If a baby is having RH incompatibility, what can happen to that baby? Yes?
There will be immunization.
Baby will be
There
okay,
will be
but
antibody formation against the
neonatal jaundice.
Yes, I already got the answer. Very good. Students are saying hemolysis can happen, and after that hemolysis there will be jaundice. Very good. Excellent. Now let me explain a little bit about this so that everybody know what's going on here. In rhesus isoimmunization or RH incompatibility disease, the mother is already having antibody against the fetal RBC. So those antibody have already transmitted towards the baby. Remember this, these antibodies are IgG type. They can cross the placenta and they have already gone towards the baby. Now, if that baby is born, if that level of antibody is high, then there is high chance of hemolysis. And after hemolysis, there will be jaundice. If the jaundice is severe, I need to admit this baby in the hospital. I need to start phototherapy and probably exchange blood transfusion is also needed. So these are serious things. We'll talk about this in some appropriate classes. Maternal diabetes mellitus. What can happen to the baby after birth if the mother is diabetic? Yes.
Sir,
So the baby
hypoglycemia.
will get hypoglycemic.
Hypoglycemia, sir.
Hypoglycemia.
Very good. The baby has a high chance of hypoglycemia. Now there is a interesting explanation for this. Okay, so please listen here. Now diabetes mellitus in the mother means there is excessive glucose level in the mother. Now before the birth, the glucose can easily goes towards the baby by crossing placenta. So before the birth or when the baby is still inside the uterus, no problem. It doesn't lead to hypoglycemia. Nothing will happen. But after the birth, that constant supply of the glucose through placenta is cut off, isn't it? After the birth, the glucose cannot come from the mother side now. But that constant presence of glucose is still there in the blood. Now what will happen? That presence of glucose is doing one big problem in the baby's body. It is stimulating those islets of Langerhans, especially the beta cell. So those beta cells are releasing a lot of insulin. Okay, it is already happening even before the birth. Now, after the birth, those beta cells continuously secrete the insulin, but the maternal supply of glucose is cut off. And what is the role of insulin hormone regarding glucose? What insulin does to the glucose? Yes?
Glucose
Transfer
to the
glucose
tissue.
into the cells.
Glucose
Transfer
insulin
glucose
starts the
to the
process of glycolysis, then glucose will be transferred into the form of ATP.
Okay, now fine, very good. So listen here. So insulin will push the glucose into the cell. Without insulin, okay, there are certain cells which can take glucose without insulin. Let's not talk about them. They are the minor population. But the majority of the cells in our body need insulin to uptake the glucose. So what the insulin will do, it will push glucose into the cell. Okay, then glucose will be utilized by the cell, like glycolysis, ATP production, and everything. So what I'm saying here, in the presence of insulin, that okay, a baby will develop hypoglycemia. That's why baby who is born from diabetes mellitus mother has a high chance of hypoglycemia after birth. Never forget this explanation. It is not by insulin which is transmitted, okay, or transferred from the mother to the baby. It is not by maternal insulin. Many of the students think like this. This is a wrong explanation. Insulin cannot cross placenta. It is because of the baby's own insulin, which is stimulated by that glucose, which is coming from the mother. Now, another, baby which should be monitored in the nursery is a baby who is having respiratory distress or other systemic problem. This type of baby may need oxygen therapy. And baby with gross congenital malformations also needs observation or some treatment before we transfer the baby to some other centers. Sometimes we don't tell this show this type of baby to the family directly. We make ourselves ready. We give certain time to the family, then only we'll show those type of baby to them. Otherwise they don't want to see. For example, how can I show a baby with anencephaly directly to the family? Ultimately I have to show, I'm not saying that, but we should prepare for that situation. Now let's move on. Now let's talk about how we diagnose congenital malformations early. Are there some clues for the diagnosis of congenital malformation or not? Very important question, you can be asked in the exam, in the MCQ paper as well. Now see here, if there is polyhydramnios in mother, it may be associated with obstruction in the upper intestinal tract like esophageal atresia in 25% and obstruction of the duodenum and upper jejunum in 75% of the case. This is known as esophageal atresia, duodenal atresia, or jejunal atresia. It is very commonly associated with polyhydramnios in the mother. I'm sure you already know this point. Another one, if mother is having oligohydramnios, means less amount of amniotic fluid, the baby may not have any kidney. It may be a case of bilateral renal agenesis. Kidneys are not developed, and without kidney, urine is not formed, and without the formation of urine, amniotic fluid volume may be less. So look at the connection there. If this type of babies are born, okay, their body, especially the face, is compressed, okay, by the uterus. Because of constant contraction of the uterus, the face is compressed. This is called Potter facies. I'm sure you have studied this in pathology. Potter facies. So this is oligohydramnios and polyhydramnios, and how we suspect about the congenital malformation. Now, another important point, if there is a single umbilical artery. Now, how many umbilical arteries are there in the umbilical cord? How many?
Two, sir.
Two umbilical artery.
Two. Very good. Two umbilical artery, one umbilical vein. That is normal. So if there is only single umbilical artery, then it may be associated with some of the congenital anomaly, like esophageal atresia again, imperforate anus, and some genitourinary anomaly. Now, esophageal atresia means esophagus is not formed. Okay, it is indented blindly. There is a big gap between the two ends of the esophagus. Imperforate anus, the anal opening is not there. And genitourinary anomalies, there are so many. Okay, so many. We can give. For example, one kidney is absent. There may be horseshoe kidney. There may be hypospedia. There may be epispedia. There may be pelvic kidney. There are so many anomalies we can list. And for orifice patency, we examine for anal patency and nasal patency both. If the baby has already passed meconium inside the uterus right after the birth, okay, then anal patency is normal. The anus is patent, means there is an opening. You don't need to worry. But if the baby has not passed stool till 24 hours after the birth, this examination is the must. Nasal patency, if the baby is showing some signs of breathing difficulty, okay, especially at the time of feeding, if the baby become blue or restless, then probably this may be a case of guanal atresia. Okay, it may be a case of guanal atresia. Now let me write that point here for you. Guanal atresia. This guana is a posterior-most part of the nasal cavity. When it is connected with the nasopharynx, that area is not developed in some of the babies. Now what happens when the babies are feeding? Okay, when the babies are feeding, then the mouth is completely blocked by the breast, and if nose is also blocked because of the guanal atresia, this baby will be hypoxic, so become irritable as well as cyanosed. These are the important points. Now, after this, okay, we examine for cleft palate. Whether cleft palate is there or not, it is very easy examination. Just look inside the mouth. Cleft palate means there is a big gap in the palate. Imperforate anus, when the orifice of the anus is not patent, we call it imperforate anus. Okay, it is a bit of different topic. And then patency of esophagus should be checked in this type of situation. What are those situations now? If the baby is excessively frothing and drooling of saliva. Now, in this situation, the patency of esophagus has to be checked for esophageal atresia. Now, can anybody answer me why the baby drools the saliva or froth excessively in esophageal atresia? What is the reason for this?
Sir, in
Sir,
esophageal
because
atresia, there is no swelling of the saliva. That's why it rolling of saliva.
Yes, okay, absolutely correct. This is the explanation I was searching for. Now, listen carefully here. Esophageal atresia means esophagus is blind. It is not connected with the distal tube. Okay, there is a big gap between the proximal end and the distal end of the esophagus. Now, that blind tube will get filled after some time. Okay, and when that tube is filled, then saliva would come out as a froth, and this is called drooling of the saliva. Very, very important clue the baby is giving, okay, for esophageal atresia. And how to confirm it now? I will pass a red rubber catheter inside from the oral cavity deeper inside. And if that rubber catheter coils there and return back, it is almost sure that esophagus atresia is present. In case of single umbilical artery, esophageal atresia may be there. In polyhydramnios, esophageal atresia is a very common feature. You already know about it. Maternal diabetes also can have esophageal atresia, and small for dead baby also can have esophageal atresia, but not that commonly. Now, these are the routine systemic examination we do after birth, and they may detect some other congenital malformation like pneumothorax. Okay, pneumothorax, then diaphragmatic hernia and abdominal mass. Now, some of them may be associated with some pathological lesion like pneumothorax. Now, what is pneumothorax? Every student know. It is the collection of free air in the pleural cavity. Collection of free air in pleural cavity is pneumothorax. There are so many causes for this. It has to be detected if it is present. Otherwise, the baby may suffer from hypoxia. Diaphragmatic hernia. It is known as congenital diaphragmatic hernia, which is very common on the left dome of the diaphragm. And the common organ which herniated up are stomach and the intestine. Stomach and the intestine. Now, what happens when they are present in the thoracic cavity? Okay, when they present there, what they do? They will compress the lung. So the development of the lung is a problem in diaphragmatic hernia. This is the first thing. Second, after the birth of this type of baby, they become hypoxic because of a very small lung, which is known as pulmonary hypoplasia. Now we resuscitate this baby with ambu bag. We apply mask which cover both nose and mouth of the baby, and then okay, we give air. Now this air will go into the lung as well as into the GI tract. When it reaches the GI tract, the stomach and intestine are again distended further. So they will give more pressure to the lung. So by doing ambu bag, I am making the baby more sick than before. The baby will become more hypoxic than before. Remember this very, very important point. So a good doctor will immediately identify ambu bagging is not the solution here. So they will take the endotracheal tube with the help of laryngoscope. The endotracheal tube is kept inside the trachea and it is connected to the ambu bag. Now all the air will directly go to the lung and the baby will become all right. The oxygenation will become all right. Okay, I'm saying that. This is called congenital diaphragmatic hernia. So if your teacher asks you this question, can we do ambu bagging, okay, with mask, okay, it is called bag and mask ventilation. In case of diaphragmatic hernia, your answer is no, because the condition will become even worse. Rather than that, I will do endotracheal intubation, attach the ambu bag directly to the tube, and then give oxygen. Now, sometimes the abdominal mass may be present because of some malformation of the kidney maybe because of hydronephrosis or because of some tumor, and we can diagnose them after abdominal exam. Now, what are the other routine examination of the baby? Now you have already transferred the baby to nursery. So in nursery also you will do this test or examination, like what is the color of the baby? The normal color is pink. Blue color is never normal. Yellow color is never normal. And pale color is also never normal. Now pink color is normal. So yellow color means jaundice. Blue color, cyanosis. And pale is anemia. So these are important points regarding the color. Respiration, I already talked about. You count the respiration for full 1 minute. Okay, full 1 minute. It is very easy to count respiration in a baby. Just focus on the rise of abdomen. Just focus on the rise of abdomen for 1 minute. You count how many times it rises up. That is respiratory rate. It should not cross 60 per minute. That is the upper limit. Examine for the movement of limb. Examine for the posture of the baby and alertness of the baby. How alert is the baby? A healthy baby should be alert. Now, at this time, I will take the weight if this weight was not taken before. Okay, but usually it is already taken at the time of birth. But length, head circumference, chest circumference, and abdominal circumference were not taken at the time of birth. So this is the time I take them and plot into a chart. They should be plotted in a chart. Then only it will give a meaning. I'll show you that chart, okay, in the next slide. Let me complete this first. The normal measurement, okay, regarding the length, the average is 50 centimeter. We already talked, but there may be a range like 47 to 50, or maybe you can say 47 to 52 or like that. Head circumference is 35 plus minus 2, means 33 to 37 is considered normal. If gestational age estimation was not done before, this is the time we do that. Okay. Now, all of you, please focus on the screen. Look at this graph. So what this graph is telling us. Now see here. Let me explain this. Very, very important knowledge. This is the, okay, this is the month. This is the age of the baby. This is the age of the baby, and this is the weight, for example. Okay, weight and the age. Now there are three curves you can see. This is the uppermost curve, this is the middle curve, and this is the lower curve. So normally we call it 95th percentile, 95th percentile. This is 50th percentile, 50, and this is 5th percentile, 5th. So for example, the baby is, born here, and this is 1 month. So we take the birth weight as well as 1 month weight here, and we are, okay, we are tracking it. So continuously the weight is taken, and there is a graph formed here. Please see here very carefully. Till this point, the graph is normal because the direction of this graph is going normally. But something has happened here, and suddenly the direction of the graph is coming distally or downward. This is called loss of weight. Something has happened at this time. Probably the baby is sick, okay, for certain duration. So the nutrition of this baby is not good enough. So this type of information can be, okay, obtained by this graph. Very, very important in pediatrics. Now let's move further. Now, what are the physical signs which suggest a premature baby? Now sometimes what happens, the lady is not sure about her menstrual cycle or last menstrual period. So we don't know what is the gestational age of this baby. So we need to make sure whether the baby is premature or mature. So these are the different physical signs. Examine the genitalia. In male baby, okay, if the baby is premature, the scrotum is very small with few rugosity. In a full-term baby, the rugosities in scrotums are complete, and testes are present at the external inguinal ring in preterm baby. They are not even present inside the scrotum. They are not even descended completely, because the descent of the testes occurs at the term. Okay, so this is important point in male baby. While in female baby, the labia majora are widely separated and labia minora are exposed, okay, as well as clitoris is exposed. So this is the important point. So what I'm saying here, in preterm baby, if she is a female baby, okay, this is the finding. In preterm baby, the nodule of the breast is less than 5 mm in diameter. This is not properly formed. In full-term baby, it is more than that. Regarding the ear cartilage, in preterm baby, it is deficient with poor elastic recoil. In full-term baby, okay, it has a good elastic recoil. It will go back to its original shape very quickly. Regarding the hair, it looks very woolly. This is called fine or fuzzy hair. Okay, so these are the different points which will tell us this baby is a premature baby or fully mature baby. This is important point. We need to examine like this and then make sure whether the baby is full term or not. Let's move further. Now, what are the other basic care of the newborn babies in the hospital? We ask the sister to take skin temperature twice a day just to make sure the baby is not hypothermic or febrile. Regarding the breastfeeding, the first breastfeed should be given within half an hour. Then it should be continued every 2 hours after that. For the first 3 days, okay, one special type of milk is coming from the breast, which is called colostrum. This colostrum is thick and slightly yellow in color, and the amount is not that much. But it is very, very important for the baby. Why? Why colostrum is important for the baby? Who can answer?
Because mother do not
Containing
immunoglobulin due to
antibodies.
the
Now,
For
very
example, immune growth and repair.
okay,
Supports baby immunity.
it has got
Support the baby and passive immunization.
very good. It has got antibody. Somebody already told me. It is very, very essential for the baby because it has a lot of antibody, and those antibody will go towards the baby from the milk. So colostrum is never discarded. Some of the family believe, okay, this is a witch milk, so it should be discarded. It should not be fed to the baby. Only the good-looking milk should be fed. Nothing like that. That's a very wrong concept. Colostrum is absolutely necessary. Okay. Now, in the first 3 days, it looks like the baby is not getting enough milk. That is called physiological inadequacy, but we don't need to worry. Whatever milk the baby is getting, that's enough for the baby. Okay, you don't feed anything from outside. Full satisfaction in breastfeeding usually takes 15 to 20 minutes. The para mother, or the mother who has given birth for the first time, she probably doesn't know these things. So we need to tell her. We need to tell the family member. Okay. So there should be a good patience when they breastfeed the baby. One breast should be fed for at least 15 to 20 minutes. Then another breast should be switched. Then only the baby will get enough milk. Now, what are the criteria for adequate feeding? Now see here, this is very, very important knowledge. Baby sleeps well for at least 2 hours if the baby is fed well. Okay, there's a good sleep for 2 hours, and after that the baby will be hungry again, and another time for feeding. The baby gain about 30 grams of weight per day. This average 30 gram weight per day if the feeding is adequate. The baby passes urine more than 6 times a day if the baby is getting enough feeding. A baby who is not getting enough feeding, probably the urination is not often. During 4 to 6 week period, round the clock feeding is done. Okay, and then demand feeding can be done. Now this is a bit of discussion. Many of the mother right from the beginning they go for demand feeding, and some mother they choose for round the clock feeding. Now round the clock means, okay, uh, according to the time. For example, every 2 hours, they will feed the baby, or every 3 hours they will feed the baby. Another way is when the baby cry because of hunger, then they will feed the baby. Both are, good enough. Only thing is baby should not be hungry for a longer time. Now, how to take care of the skin, and what about the baby bath? Now, during summer, we give proper bath to the baby, and during winter, the baby should be sponged only. Now, this is because of the fear of hypothermia to the baby. But it depends what is the environmental temperature. In some of the environment, the temperature is very well maintained. So you don't need to worry, you can give bath to the baby, but you should be quick enough. Effective cleaning and drying of the skin at birth is done. Now, there is one small, knowledge I want to share with you. Many of the baby at full-term baby, okay, they have a thick, sticky, gelatinous substance attached on their body, and that is called vernix caseosa. Let me write that term here. Vernix caseosa. Okay, wait. This vernix caseosa is thick, gelatinous substance which is attached on the skin. Now you don't need to clean that vigorously, and don't damage any skin while you clean it. You don't. Okay. After 1 to 2 days, when you give bath to the baby, that vernix caseosa will go away by itself. And this vernix is actually maintaining the temperature in the baby. So don't desperately remove it. That's the point. How to take care of umbilical stump now? This is an important site for entry of spore of tetanus. So if the baby is delivered at home, we need proper instrument to cut it. Proper sterilized instrument to cut it. You don't use any knife. Whatever knife you get, from the kitchen or some other place, don't use that to cut the umbilical stump. This may be a dangerous thing for the baby. So these days, these type of kits are available very commonly or freely in the pharmacy shop or pharmaceutical shop. Those type of things should be used. Cord to be examined after 2 to 4 hours of birth, because bleeding commonly occurs at this time due to shrinkage of the cord and loosening of the ligature. So proper examination has to be done time and again. Now one small question for you. If the umbilical cord excessively bleed, okay, after the birth in a male baby, what do you suspect? Yes, who can answer this to me?
Infection.
Because of hemophilia, sir.
Very good.
Side, sir.
It's hemophilia. Wonderful. This is called hemophilia. Hemophilia is X-linked recessive disorder. That's why I ask you by giving the example of a male baby. So listen once again. A male baby who starts to bleed from the umbilical stump few hours after the delivery is highly likely to have hemophilia disease. Now, weight record has to be kept, okay, when the baby is still in the hospital, and that is done by the hospital nurses. Most of the babies lose weight during first 2 to 3 days of life because of the loss of fluid from the body. Weight loss varies between 5 to 8% of the birth weight. This much weight can be lost by the baby. So let's do one exercise here. if the birth weight of the baby is 3000 gram, 3000 gram, how much weight a baby can lose? Can you tell me? If you calculate just 5%, what is the 5% of 3000? What is the 5% of 3000? How much it would be?
150 grams, sir.
3 gram.
150 grams, sir.
Very good. 150 gram. Okay. 150 gram. Now 8% of 3000 is 240 gram, isn't it? 240 gram. So that much weight can be lost in the first week of life, and that is normal. This is physiological weight loss. After that, the baby starts to gain weight again. This is very, very important point. So birth weight is regained by the end of first week. Definitely in the full-term baby, and in the preterm baby, they may take up to 2 weeks time. Malnourished is small for dead baby. This is another term for IUGR baby, okay? They do not lose weight immediately, but they start gaining weight within 2 to 3 days after birth. This is just like marasmus. We can compare these babies with a marasmic baby. They are very hungry, okay? They can immediately start gaining weight. They don't lose weight. This is the important point. And the normal rate of weight gain is 30 gram, 20 gram, 10 gram per day during the first 4 months, second 4 months, and third 4 months respectively. Nobody is going to ask you in this much detail, but the first 3 to 4 months, it is 30 gram per day. And don't forget that. Some of the exercises will be asked to you from this simple statement. Now, immunization is one of the important things we like to do. Before we discharge this baby from the hospital, we give certain immunization, that is oral polio vaccine. We call it 0 dose, and BCG we give to the baby and discharge. Oral polio vaccine 0 dose and BCG, these are two important vaccines which we give at the time of birth. And then proper counseling has to be given. They should come back at 6 weeks for other doses. We tell them about the nutritional advice and the development of the baby and follow up in 6 week time. Now, I have come toward the end of this important topic. Okay. Now, at the end, let's talk about what are the danger signs that warrant monitoring in these newborns. If these signs are seen in the newborn, probably I don't discharge them. I'll keep them in the hospital. I'll admit them and I start the treatment. So what are these? Have a look here. Regarding the general features, if the baby is not feeding well, if there is poor feeding, we will try to find out the cause for this. And many of the time, these babies are sick. They're having infection inside. That's why they don't feed well. A good, healthy baby would feed normally. Hypothermia is a danger sign. Pyrexia or fever is also a danger sign. There's no doubt about it. Poor weight gain or excessive weight loss in the first week is a danger sign. Both. And bleeding from any area after the birth is always a danger sign. So try to find out the cause and treat accordingly. Regarding the pulmonary danger sign, tachypnea, that is respiratory rate more than 60 per minute, I already explained this to you, is a danger sign. Retraction of the chest. Now, what do you mean by that? Chest retraction means indrawing of the chest. When the baby is breathing, the chest is going inside. That is called indrawing of the chest. This is always abnormal. This means the baby is having difficulty to breathe. And apnea and grunting, these are also abnormal. Now, apnea is cessation of respiration. the baby has stopped breathing for certain duration. This is called apnea. According to the definition, if the baby doesn't breathe for more than 20 seconds, this is definitely apnea. There is no doubt about it. Another definition is also there for apnea. Okay, let me write that for you. I'm talking about apnea now. One is 20 seconds. If the baby is not breathing for more than 20 seconds, this is definitely apnea. But less than 20 seconds, for example, 10 to 15 seconds, okay? 10 to 15 seconds with bradycardia, okay? Decreased tone, as well as pale color. These are also features of apnea. So apnea has two important definitions. We'll talk about that later. Grunting is a typical grunt sound which is heard during the breathing. This is a very important feature of respiratory distress. Now, what are the danger signs regarding gastrointestinal tract? Diarrhea, okay, this is called true diarrhea. There is a reason why it is written like a true diarrhea, because the normal stool of the newborn baby looks like a diarrheal stool, okay, but that is not a true diarrhea. Regarding the definition of diarrhea, the stool frequency should be more than 3 times a day, and the consistency of that stool, okay, should fulfill the shape of the container. It should fulfill the shape of the container, then only we call it diarrhea. And the newborn baby's stool, it doesn't fulfill the shape of the container, okay, so it is not a true diarrhea. So persistent vomiting is always a danger sign. Distension of the abdomen, always a danger sign. And failure to pass meconium within 24 hours. Please remember this. Failure to pass meconium within 24 hours is always a danger sign. Who knows? The baby doesn't have any anal opening. There is intestinal obstruction. All these things has to be ruled out. Regarding the neurological features, presence of seizure is always a danger sign. This shows a serious problem inside the brain. Regarding the genitourinary system, failure to pass urine by 48 hours is a danger sign. You see that I am underlying this thing, very important for the students. Failure to pass urine by 48 hours, failure to pass meconium within 24 hours is always a danger sign. And regarding the skin, umbilical sepsis, pyoderma, and scleroderma. These are 3 important points which shows the baby is not well. These are the danger sign in the newborn. Umbilical sepsis can easily go into the portal circulation, can easily lead to septicemia. Pyoderma is a bacterial infection of the skin, and scleroderma is hardening of the skin. When we palpate that particular skin, it feels like it is tight and hard. It is a feature of sepsis as well as hypothermia. This is called scleroderma. These are very important points.